Hi, Dave Lockwood here again with Percussionaire Corporation. As I mentioned in our first video, we have received a lot of inquiries from hospitals throughout the United States and Europe wanting to know if our IPV therapy or our VDR ventilator was effective with COVID-19 patients. As I mentioned in the first video, yes, they have been very effective. And I bring you another one of our one-on-one interviews with experienced advanced clinicians from around the United States and Europe who have been using our products with COVID-19 patients. And once again, they will talk about how they've been using them. I hope you will find this series to be helpful with the use of our products in your hospital. Thank you.
Okay.
Yeah, now it's showing it.
Okay. This is our third interview in the series on COVID patients. I'd like to introduce to you John Campbell. John, can you tell us a little about yourself?
I'm a respiratory therapist. I've been in respiratory for the past 46 years. At the moment, I work as the Director of Pulmonary Services at the St. Dominic's Hospital in Jackson, Mississippi.
Okay. And from understanding, you've had quite a bit of experience with using VDR with COVID patients. I understand that you haven't been using as much IPV, but more VDR therapy. Is that correct?
Yeah, that's correct. In the past 11 months, we've had over 100 COVID patients on VDR.
So what made you decide to start using the VDR with COVID-19 patients?
Well, I had experience with the VDR from a previous hospital in Newark, New Jersey. And there we were running VDR with adults, pediatrics, and neonates. And especially the neonates, we found it very helpful because we had quite a few with bronchopulmonary dysplasia, and they would air trap a lot. So we would have problems with very high PCO2s and really failure ventilating in other ways, such as with oscillators and conventional ventilators and even with jets. So we used the VDR and we were able to blow down their CO2s plus bring their oxygen requirements down. So here with the COVIDs, what we found is almost the same thing. Our COVIDs and what I hear around the country, a lot of air trapping, a lot of high CO2s, a lot of high pressure. And we've been able to ventilate these people that were basically not, that were failing in any other conventional mean. So it's worked out really well. It's interesting because, you know, normally it's for that refractory hypoxemia that originally I was used to using the VDR, but here we've used it a lot to blow down CO2s to really help with that air trapping and still get that oxygenation push also.
Interesting. So when you started using the VDR and you've done over 100 cases, so quite a bit of experience with it, what would you say the average length of time you're seeing patients spend on the VDR ventilator?
The COVID patients have been a lot longer. I would say average, I was used to patients being on somewhere from 4 to 7 days that we would have them on VDRs. Here we've had them sometimes 2 weeks, even 3 weeks on the VDR. So it's been different in that respect. But we have most of the patients, I would say virtually all those 100 patients, we were failing other means of ventilation. And in our minds, at least, we feel like virtually all of them would have died if we didn't use the VDR.
When you use it on the COVID patients, a lot of people tend not to extubate from the VDR. They tend to go back to conventional ventilation. Is that what you have done? Or are you
That's what we've been No, we're not extubating. These patients, many of them that went to the VDR were on very high pressures. And even when we move away from the VDR back to conventional, we see some high pressures at first that over the first 24 hours, we start seeing them drop. But it's amazing where we're moving them. We're trying to get these patients under 60% oxygen and bringing their mean airway pressures down around 16, 17 on the VDR. That's our point that we look at moving to conventional ventilation.
When you first start them on, you say relatively high pressures. Are they as high as on conventional ventilation, or what are you classifying as high pressure?
No, well, on conventional ventilation, they are running, many of the patients we switch over are running over 40 centimeters, usually 40 to 50 centimeters water pressure. So on the VDR, it's all relative, but when we're using for peak pressures, I would say our average is about 35 centimeters to start with. And if we feel like we can go lower, we'll go lower. We usually match the PEEP with what the PEEP was on conventional ventilation. But we're seeing more success that way. Usually we don't go over 40 centimeters, 42 centimeters water pressure with the VDR.
Okay. What are you staying with a convective rate of 15 and 2-second I and E time, or are you adjusting those?
We're using our IE times, we're using 1-to-1 on the VDR, and we're also, our rates are a little different than what I'm used to on the pure refractory hypoxemia. Usually these people are retaining CO2, they're air trapping. So we'll start rates a little higher. Instead of 15, we'll run 17, 18 on our convective rates. Also, our percussive rates sometimes we'll start at 500, but more than likely it's going to be 450 or even 400.
Okay.
Because of the air trapping. I actually started a VDR just 3 hours ago, and I started him on a rate of 16 and percussive rate of 450. The CO2 is about 53 before we started it. So I just wanted to bring it down. He's already retaining, and he was on a rate on conventional ventilation. He's on a rate of 26. So I wanted to bring that CO2 down a little bit. He's air trapping.
Interesting. Do you routinely use, some places using the VDR don't use cuff leak at all unless they're having CO2 or secretion issues. Some people routinely use it. What are you doing as far as the cuff leak?
We're using the cuff leak when we get CO2 issues. So we will, if we see that a lot with COVIDs, and it really works well. We've also had some patients where cuffs were blown and we actually went to the VDR rather than re-intubate because they were already on 100% oxygen. We didn't want to, it's too much of a risk to re-intubate, so we just switched them over to the VDR because it'll ventilate fine with any kind of cuff leak.
You're actually the second person that's told me that, not in interviews, but I had some friends up in the New York City area, and they said it was just too fragile to change out the tube, exactly like you said. And most people tell me they're not seeing a lot of secretions in these patients. What are you seeing?
We're not seeing a lot of secretions with these patients at all, and actually, because we're running the VDR longer, we're actually using 2 heaters on the VDR. So we have 2 heaters in line. The patient that started a few hours ago, we used 2 heaters with him. They're on, when we put somebody these days of COVID, I start thinking it's going to be a week on the ventilator at least. And it just seems like that's what plays out now. The patient today, he was on 20 of nitric also, and on his conventional ventilation. I was able to bring the nitric down to 15, and we actually improved his oxygenation.
Does your facility do ECMO at all?
We don't do ECMO. Actually, where we sit, we are, our property is up against the University of Mississippi's property. So the hospital's right next door to us, and they do ECMO. But we have a patient that about 8 weeks ago actually had bilateral pneumothorax, is spontaneous, before he was ever intubated. He was intubated after he put the chest tubes in because the SATs wouldn't come up, still couldn't ventilate, and we went right to the VDR. They tried to get him for ECMO to transfer him. They didn't have any room because they were covered up with COVID patients. So they couldn't accept him for ECMO. That was 8 weeks ago. That patient today is, he was trached, but he's been decannulated. He's off a ventilator. He's home today. So he's done very well.
That's what I've heard with some people, that same thing, that they couldn't transfer for ECMO, and they put him on the VDR and they never needed him.
Sorry.
That's okay.
Sorry about that.
It's okay. So yeah, that echoes a lot of people that are really comfortable with the VDR actually obviating the need for ECMO, or using it if they went on ECMO. I've had a couple people say conventional ventilation, they weren't able to get them off, and they switched, still on ECMO, had switched to the VDR and were able to decannulate. Any concerns with?
Well, in my last hospital, we did do some VDR with ECMO. So we did do that, and you can do decrease the pressures and kind of a lung conservation type. But we didn't do it a lot because we had a number of patients that were transferred in for ECMO that we went to VDR, and we were able to avoid ECMO. So it was really good for patients. We had quite a few actually that were transferred for ECMO and never went to ECMO.
This was in your previous employment, and it wasn't necessarily COVID patients at that time, was it?
No, most of those I would say were severe pneumonias, a lot of non-COVID viral pneumonias.
Yeah, interesting. I know of another facility, they actually have a mobile ECMO team, and they started taking the bronchotron with them and to transfer back. And they ended up never putting.
Well, and that's what we were doing, that with the bronchotron, because we did a lot of external transports. So we used the bronchotron a lot, especially for neonatal. But if we had, if we went out for a patient that they were looking at ECMO, if we decided, usually what we did was we put them on the bronchotron in the other facility. And if they held up pretty well, we didn't start ECMO. We brought them back on the bronchotron and would switch over to VDR and watch them. And an awful lot of them did not go to ECMO. The vast majority did not go to ECMO.
Very good. With the VDR and the ECMO patients, or not the ECMO, but the COVID patients, any concerns with aerosolization? I've had people say in other facilities they want to use the VDR, but they're concerned about aerosolization and cuff leak technique. What is your experience?
We're aerosolizing using aerogen for nebulization for treatments. Now, on these COVID patients, we're putting.
I'm sorry, the aerosolization
didn't catch
about is oral secretions or anything of that nature. So they're worried about using the VDR because they think they're going to aerosolize contaminants out of the lung and the back of the throat.
No, we, well, of course, most of the time we're leaving the cuff up, but no, that really has not been an issue. We're using N95s, face shields, full coverage. Now on the circuit, we're adding HEPA filters two areas on the circuit. We've been doing that since day one on the VDR circuit. So I can't say that we've had any kind of contamination with the staff or anything. I don't really think so. Like I said, we've run a lot of patients. Yeah.
And generally, we're putting these patients in negative pressure rooms. So though I know some older facilities haven't had enough negative pressure rooms. But then I also know of some other facilities that are quickly able to change over positive pressure rooms to negative pressure. When you finally send these patients, they go from VDR to conventional vent to extubation with these COVID patients. How much support are they needing post-extubation? Are they going from that to BiPAP or high flow, or what's your experience?
It's a mix. Most of them, first of all, most of them, when we've gone to conventional ventilation, a number of them have gone on to LTACs, for long-term care. So, when they're down there in conventional ventilation, 40%, 30% oxygen, and we may be working with them still, if there's a bed in an LTAC, a lot of times they're transferred. A lot of them, we've been doing support. They really have a lot of metabolic issues and a lot of renal failure and other things. So they're we get them over the ventilator hump, but we still are supporting them some because they're metabolic acidosis. But when we extubate, we really have not been going to, have not had to use a lot of BiPAP, a lot of non-invasive. Haven't done that a lot. But it's situational with them. The one thing they probably haven't needed is any high levels of oxygen. Usually when we're extubating, they've done pretty well, can stay on a cannula at lower flows. We haven't had to use any high flow devices or that post extubation.
Great. This has been very good, John. I think a lot of people are going to find this helpful. Anything you can add if people are going to choose to try the VDR with COVID patients that they should look out for or they might see occur?
When you're dealing with these COVID patients, there is a lot of air trapping. You have to be able to kind of anticipate that and be able to, what I would say, stay ahead of it with your settings. Don't get behind on it. It's interesting because I think it's a game changer. We believe that we've been able to wean about 30% of our VDR patients, wean over to conventional. How patients do in the long term, some of that's dependent on their renal failure, but we've had some really great successes, I would say, some really good things happen. And, when you say 30%, that 30%, we felt like if they were on conventional ventilation and stayed with it, they would have been 100% would have died. So we believe that we're making a difference with them.
Sounds good. COVID aside, what's your opinion with so much experience now with the VDR? Everybody sees it as I don't put them on a VDR until I have to rescue them or salvage them. But my thought is if possibly we started sooner, would we not have to get to that rescue or salvage stage with the VDR? I'm a firm believer of starting ahead of the curve rather than behind the curve. But what's your experience? Is it just a rescue mode of ventilation, or would you put it on someone right from?
No, we've started some of the patients right at intubation. We really felt like we needed to. Plus, we were even trying to avoid things like nitric oxide. If we could intubate them, we might not have to start that nitric on the ventilator. We may be able to take care of that hypoxemia. But there's also physicians that some of them kind of wait, and maybe in that hopeful mode that they're not going to progress, and they are using it semi-rescue, I'd say. They reach a point where the patient is, we're not able to maintain an adequate oxygenation, plus they're starting to retain CO2, and they move to the VDR. So it's been a mix. I'd rather do it earlier. I would rather start off earlier. I would say the patients we started off earlier seem to come off a little bit earlier from mechanical ventilation. So it's all dependent, and it's hard to say. So much goes into it. Age makes a difference. And even that, we've had patients that are older that have surprised us and done well on the VDR to be extubated, and we've had young ones that we thought would do better than they did. So it's just a real mix. Just depends on how bad their whole COVID big picture is, I guess, because we have so much else going on just besides the pulmonary part. A lot of times with the VDR, we get them past that, their pulmonary issues, only to have other issues such as, renal failure that really gets them in the end.
Yeah, this COVID is really, and I've been doing respiratory care for about 42 years, and I've not seen anything like this. I mean, you hear about a 117-year-old nun, I think in France, had COVID and survived, and then you have a 38-year-old, looks like the picture of health, and they pass on.
Yeah.
It's just nothing like it. I thank you very much for your time. I think this is going to really be valuable for a lot of people, and I appreciate it. I know you're busy. And on behalf of Percussionaire, thank you.